The objectives in this talk will be to review a few classic inflammatory skin diseases affecting the epidermis, the dermis, and the subcutis. And with each of the entities that I'll talk about, I will also address the pathophysiology. So among the reaction patterns that will be considered are with respect to epidermal changes or epidermal inflammatory conditions, eczema, psoriasis, and the interface dermatitis of collagen vascular disease. With respect to the dermis, I'll just talk about two entities, vasculitis and urticaria. And then finally, we'll briefly talk about inflammatory disease of the fat or panniculitis. Now, I think it's important to understand that many of the inflammatory reaction patterns that we see in the skin can be linked with the classic Jelen-Coombs hypersensitivity reactions. And when I look at my cases every day, I always try to think of the inflammatory process in terms of the pathophysiology, since I think it does help clearly in determining etiology. So what are the four basic reaction patterns? Well, the type 1 is cross-linking of IgE bound to high-affinity Fc receptors on mast cells and basophils via an allergen leading to mast cell degranulation, best exemplified by hives and anaphylaxis. Type 2, which is a very important type of hypersensitivity that we see in the skin, is where you have antibodies that are targeting cell or matrix, like the basement membrane zone. And that would be best exemplified by lupus erythematosus and any of your autoimmune vesicular bullous disorders, as we'll talk about in greater detail, and actually chronic idiopathic urticaria. Type 3 is immune complex disease, immune complex hypersensitivity, where circulating immune complexes trigger a vasocentric inflammatory process, a leukocytoclastic vasculitis. Immune complexes are implicated in dermatitis epidemiformis. And then finally, type 4 is where you have T cells that are responding to soluble exogenous antigen processed by antigen-presenting cells, which would be delayed type for hypersensitivity, or where you actually have a cytotoxic CD8 T cell response to endogenous cellular antigen, which is cytotoxic type 4 immunity. And that would be exemplified by eczema for your delayed hypersensitivity versus the cytotoxic interface conditions like erythema multiforme. And again, we'll go into some detail. So we'll start off, first of all, with epidermal reaction patterns, and we'll consider those epidermal reaction patterns that are really reflective of type 4 hypersensitivity. And let us, first of all, address eczema. And there are two common forms of eczema: an allergic eczematous dermatitis, which is usually triggered by a contactant, occasionally a drug. Can be the allergen, and that relates to cross-reactivity of a drug with a topical agent to which the patient may have been previously sensitized. And the other type of eczema is atopic eczema. And atopic eczema is part of an atopic diathesis, which also encompasses hay fever, allergic rhinitis, and asthma. These patients typically have high serum IgE levels and peripheral blood eosinophilia. It is very complex pathogenetically, and there are genetic factors that are involved. Both variants of eczema, whether one is dealing with an allergic eczematous dermatitis or atopic dermatitis, has a tremendous amount of overlap histomorphologically. And because we're focusing on inflammatory conditions that we can link with those Jelen-Coombs hypersensitivity reactions, for today's discussion, we will focus on allergic contact dermatitis. So allergic contact dermatitis is really the prototypic type 4 delayed hypersensitivity reaction. And so what is involved in the allergic contact dermatitis pathogenetically? Well, you have topical antigen application to the skin. That antigen is then bound by Langerhans cells, which are your antigen-presenting cells, and they will migrate to the lymph nodes, the Langerhans cells containing this antigen, where there will be an interaction between very specific antigen responsive T cells that recognize that specific antigen and the Langerhans cell. And when that interaction occurs between the Langerhans cell having the antigen bound to those specific T cells, you will get expansion of memory T cells. And that expansion phase is anywhere from 14 days to 28 days, hence the designation of so-called delayed. And then when you are re-exposed to the allergen or the hapten, those antigen-specific T cells will proliferate, migrate to the skin, and result in an allergic contact dermatitis. And that phase is the elicitation phase, which happens actually rather rapidly, between 1 to 2 days. So this would be really a very classic example of allergic contact dermatitis, which is basically poison oak dermatitis, where the allergen is this pentadecatechol catechol, and that particular allergen elaborated from the poison oak will interact with the Langerhans cell, and that will in turn bind specifically to very antigen responsive T cells that will in turn subsequently elaborate interferon as well as macrophage inhibitory factor and macrophage chemoattractant factor that will basically lead to the influx of monocytes into the tissue with the release of lytic enzymes that contributes to enhanced vasopermeability, ultimately resulting in this vesicular eczematous reaction that you're seeing clinically. And what does one see histomorphologically? Well, essentially, those sensitized T cells that recognize the antigen and elaborate these factors that will attract monocytes, and in turn there is this local tissue injury, will be characterized histomorphologically by an exocytosis of T cells into the epidermis, where they are intimately opposed with Langerhans cells, which of course are those antigen-presenting cells, and plus you have an influx of other cell types related to the elaboration of various factors from those sensitized T cells, specifically monocytes. With the release of lytic enzymes, there's enhanced vasopermeability with the elaboration of serum into the surrounding tissue, resulting in this edematous appearing epidermis with intraepidermal vesiculation, where the vesicle is composed of serum, Langerhans cells, monocytes, as well as T cells. So essentially, this vesicular reaction clinically translates histomorphologically into this eczematoid delayed dermal hypersensitivity reaction with all those cellular constituents being represented in the epidermis. So now we'll talk about another type 4 hypersensitivity reaction, which is not the delayed, but rather the cytotoxic. And we'll start, first of all, with erythema multiforme. So that is a self-limited cytotoxic CD8 immune reaction directed at self-keratinocyte, where the keratinocyte has been rendered antigenic either by binding an exogenous antigen, that is a hapten, or through the process of molecular mimicry. And so what are the commonest antigenic triggers to evoke this cytotoxic CD8 type 4 immune response? It could be a microbial agent, specifically herpes simplex, and there one would have to infer that a microbe could cause this reaction perhaps through molecular mimicry. The other would be drugs, where the drug is functioning as a hapten. And rarely a contactant can actually evoke this type of cytotoxic CD8 immune response. And so here we have a patient who has herpes labialis, and every time the patient developed herpes of the lip, they developed erythema multiforme minor, characterized by these targetoid lesions on the palms of the hands. So it was a very self-limited type of cytotoxic CD8 mediated interface process, pretty much localized to the palms of the hands. And so what you're seeing histomorphologically are these cytotoxic CD8 T cells that are targeting the epidermis because they're recognizing the keratinocyte as antigenic. And one would have to postulate that the herpes simplex some antigenic component of the herpes simplex presumably cross-reacts with keratinocyte antigen. So this is an example of molecular mimicry, likely, that evokes this cytotoxic type 4 immune response. Now, a very severe sort of variant of this cytotoxic CD8 reaction triggered by an exogenous antigen and typically a drug is Stevens-Johnson syndrome as well as toxic epidermal necrolysis. And in Stevens-Johnson syndrome, the epithelial injury is striking and has a mucosal proclivity, so it involves the mucosal surfaces, conjunctiva and mouth, and they can develop concomitant erythema multiforme-like lesions. In toxic epidermal necrolysis, there is diffuse necrosis and sloughing of the skin. Mucosal involvement can also be seen, but it tends to be of lesser severity than what we see in SJS. And in general, in SJS, the amount of skin involvement is less than 10%, while in toxic epidermal necrolysis, the sloughing of the skin is quite impressive and typically more than 30% of the body surface area. Sometimes you have patients that have a combination of both TEN and SJS. And as opposed to erythema multiforme minor, which I showed you, where you can have a microbial pathogen as the typical trigger, in this severe cytotoxic CD8 reaction, the classic trigger is a drug. So here we have a patient who has toxic epidermal necrolysis, where you have this very striking sloughing of a significant part of the body surface skin. And so what does one see, whether it is TEN or SJS? There is profound and extensive keratinocyte injury, far in excess of what we see in erythema multiforme, triggered by an infection. So here we have confluent epithelial necrosis. And I think it's important to know that there's somewhat of a disparity between the massive degree of keratinocyte necrosis and the relative lack of in vivo lymphocytes. So a lot of the necrosis in the skin in these severe conditions, SJS and TEN, occur independent of in vivo lymphocytes and probably relates to the sensitized circulating CD8 lymphocytes elaborating Fas ligand, and that soluble Fas ligand binds to Fas on keratinocytes to result in this dysregulated excessive epithelial necrosis. And there are, of course, some of these sensitized T cells in vivo that we can highlight with an immunohistochemical staining protocol, specifically an immunostain that recognizes CD8 T cells, and these CD8 T cells are cytotoxic T cells that will contain granzyme, which we can also highlight immunohistochemically. But again, the in vivo lymphocytes, although contributing to the keratinocyte injury, are not entirely responsible. A lot of it relates to circulating soluble Fas ligand, probably. So all three conditions are an idiosyncratic response to drug, and or at least with erythema multiforme, it could be a microbe, but SJS-TEN is typically drug, where you have a peptide binds to the keratinocyte surface HLA-B protein. That's one mechanism versus molecular mimicry. Molecular mimicry being typical for infection-triggered erythema multiforme minor. And then you have an MHC class 1 restricted type 4 immune response directed at squamous epithelial cells, and the actual keratinocyte injury is going to be mediated by Fas ligand bound to Fas on keratinocytes, whether it's either exclusively in vivo, as you would see with erythema multiforme, or a lot of soluble Fas, as you would see with TEN and SJS. So now we'll talk about another type 4 mediated T cell process, which is psoriasis. And of course, the prototype is psoriasis vulgaris. It preferentially involves the scalp, groin, elbows, knees, umbilicus, lumbar spine area. I'm not going to go into too much detail about this clinical because I know you have lectures on psoriasis. And here are just some clinical images. And again, this is just a brief introduction to the clinical aspects of psoriasis. And there are subtypes of psoriasis, like erythrodermic psoriasis, pustular psoriasis, infection-triggered guttate psoriasis, characteristically triggered by streptococcal infection. So here we see psoriasis vulgaris over the knee with the silver plaque, as opposed to the pustular psoriasis presenting with the coalescing pustular foci on the plantar aspect of the foot. So what does one see histologically, regardless of the psoriasis subtype, whether it's erythrodermic psoriasis, psoriasis vulgaris, or guttate psoriasis? There's an element of commonality morphologically that reflects the pathophysiology. So number one is you do get a hyperplasia of the epidermis, and it's a regular pattern of psoriasiform hyperplasia with elongate retia. Oftentimes the retia are disproportionately elongated and the suprapapillary plates are quite thin. Secondly, the dermal papillae capillaries have a very distinct alteration. They become dilated and the basement membrane zones become juxtaposed to the basement membrane zone of the epidermis, referred to as the psoriatic capillary, a very unique finding for psoriasis. Thirdly, it is an autoimmune Th1-mediated process. So very intrinsic to the histology of psoriasis are those Th1 T cells. So we do see a lot of lymphocytes that are accumulating in the dermal papillae and show this directed pattern of migration to the suprapapillary plates. In addition, the T cells that are targeting the epidermis elaborate specific cytokines that will result in the migration of neutrophils into the skin. So another cardinal hallmark of psoriasis are all the neutrophils in the stratum corneum and also coursing through the spinous layer of the epidermis. Not that the spinous layer neutrophilic infiltrates are particularly well exemplified here. So there probably is a role for molecular mimicry between certain keratins that are aberrantly expressed in the epidermis and an infection, specifically streptococcus. So when you look at guttate psoriasis, which is that eruptive form of psoriasis, it is typically temporally associated with streptococcal exposure. And these autoimmune Th1 cells that are targeting the epidermal keratinocyte are elaborating very specific interleukins like IL-8, IL-23. As well, those Th1 cells will elaborate IL-17, and they're referred to as Th17 cells. And basically, the IL-8 and IL-23 contribute to the neutrophil migration and to the epithelial injury that occurs in psoriasis. And of course, when you look at biologic agents, they are really targeting those Th1 cells and very specifically those interleukins that mediate the inflammatory response in psoriasis. So now we'll move on to a different type of immune reaction involving the epidermis. So we talked about type 4 immunity. Now we'll move on to type 2, which is to say you have an antibody that is targeting the epidermis. And that would be best exemplified by lupus erythematosus. And there are three basic subtypes of lupus. We have systemic lupus, subacute cutaneous lupus, and discoid lupus erythematosus. And here is an example of a patient who has a photodistributed rash with malar erythema. Very typical in lupus is that the epidermal injury, which is antibody-mediated, occurs in the context of sun exposure. So it is a photodistributed dermatitis. In the image on the left, one can see these polycyclic annular patches, again photodistributed, involving the upper back and arms. That is typical for subacute cutaneous lupus erythematosus. And unlike systemic lupus, where there is multi-organ involvement, and really any organ can be involved, such as the lung, the kidney, the brain, in subacute cutaneous lupus, there is significant skin involvement, but that defines the antigenic target. It's just the skin. There isn't any multi-organ involvement per se. These patients are characteristically anti-Rho positive. the skin rash is extensive but non-scarring. In contradistinction, in discoid lupus, that too is cutaneous confined, very limited to the head and neck area. And unlike subacute lupus or even systemic lupus, which is typically non-scarring, this variant of lupus, in fact, can produce significant scarring, including permanent hair loss. And most patients with discoid lupus have a cutaneous confined process without evidence of systemic lupus. And regardless of the subtype of lupus, whether it's systemic, subacute, or discoid, a Jelen-Coombs type 2 immune reaction is implicated, which is to say that you have antibodies that are binding to the epidermal keratinocyte. And those antibodies will recognize the keratinocyte with sun exposure. So with sun exposure, there is apoptosis of keratinocytes. Antigens are displaced to the surface, and they're recognized by these autoantibodies. Now, there are FC receptors on T cells, and those FC receptors will bind to the antibodies that in turn are bound to the keratinocyte, and that will result in injury to the epidermis that is mediated by T cells, but it's referred to as antibody-dependent cellular immunity, where you have those T cells with FC receptors binding to immunoglobulin, which in turn is bound to the keratinocyte that is rendered antigenic with light exposure. The antibodies themselves, independent of T cells, activate the classic complement pathway, and the effector mechanism in complement pathway activation is the membranolytic attack complex, which will drill pores into the cell and also contribute to the epithelial injury that we see in lupus erythematosus. And so here we have an image of an epidermis that is very thin. It's atrophic or attenuated. You have lymphocytes that are in the epidermis, and those lymphocytes are T cells that are recognizing the antibody through the FC receptor and causing keratinocyte injury through the mechanism referred to as antibody-dependent cellular immunity. In addition, there is a component of epithelial injury that reflects classic complement pathway activation, where the membranolytic attack complex C5b-9 is also contributing to the epidermal injury and the progressive resorption of the epidermis. So now we'll move on to the autoimmune vesicular-bullous disorders, and we'll talk really about a few of them: pemphigus, pemphigoid, and dermatitis herpetiformis. So let's first of all address pemphigoid. So this is a disease of the elderly, but of course it can occur really in all age groups. And clinically, one sees large, tense bulla. It tends to be a very pruritic eruption, so pruritus is quite characteristic. Oral lesions are seen in about a third of patients. And bullous pemphigoid can be triggered by some exogenous event, trauma, burns, sometimes drugs. So what does one see histomorphologically? Well, it is this blistering eruption whereby under the microscope one sees the presence of a subepidermal blister, which is to say that the epidermis is separated from the dermis. And it is very characteristic in bullous pemphigoid to see this striking accumulation of eosinophils within the blister cavity. So it is the classic entity that produces an eosinophil-enriched subepidermal blistering dermatosis. So what is its etiologic basis? Well, it's basically a Jelen-Coombs type 2 immune reaction where an antibody is recognizing the basement membrane zone as antigenic. And we can highlight that antibody through a technique referred to as direct immunofluorescence. With direct immunofluorescence, we use frozen fresh tissue that is incubated with a fluorescinated, tagged anti-human IgG, and that will detect the in situ deposits of human IgG. The IgG leads to mast cell degranulation, a release of eosinophilic chemotactic factor. But over and above antibodies of IgG isotype implicated in bullous pemphigoid, IgE antibodies are implicated and almost certainly contribute to the accumulation of eosinophils within the dermis and in the blister cavity. So what is one seeing in this immunofluorescent picture? Well, up here is epidermis, down here is the dermis, and what is outlined in a homogeneous, thin, linear pattern is the epidermal basement membrane zone. And it shows the classic picture that we look for as dermatopathologists when we're looking at direct immunofluorescent samples, which is this distinct, intense, N as in Norman, serrated, linear staining pattern within the epidermal basement membrane zone for IgG. And it is that antibody that basically disrupts the epidermal basement membrane zone and leads to that epidermal-dermal separation, plus the elaboration of the eosinophilic chemotactic factor that contributes to the inflammatory milieu in bullous pemphigoid. So what are the antigenic targets in bullous pemphigoid? They're largely categorized into bullous pemphigoid antigen 1 and bullous pemphigoid antigen 2. The bullous pemphigoid antigen 1 is intracellular within the basal layer keratinocyte, localized to the hemidesmosomes, weighs about 230 kilodaltons. The bullous pemphigoid antigen 2 has both an intracellular and an extracellular component. And the part of the bullous pemphigoid antigen 2 that is antigenic in bullous pemphigoid is the extramembranous non-collagenous domain within the BP antigen 2. So it's actually a specific portion of the BP antigen 2 that is implicated in bullous pemphigoid. So this is a graphical abstract of the basement membrane zone. So we have the basal layer keratinocytes, and we have the lamina densa, anchoring fibrils, and dermis. And if you take a piece of fresh skin and incubate the skin with saline, normal saline, you will induce a split in the basement membrane zone. And that split will lead to the localization of antigens above the salt split versus those antigenic targets below the salt split skin zone. So in bullous pemphigoid, the antigenic epitopes that are implicated, which is BP antigen 1, which is purely intracellular, localized to the hemidesmosomes, is above the salt split skin zone, as opposed to, and also the BP antigen 2, the extramembranous non-collagenous domain, which is here, is also above the salt split skin zone. And why that is important, what we can do when we have these immunofluorescent samples, I can instruct the technician to take that fresh sample, incubate it in saline, and repeat the assay. And that saline incubation will separate the epidermis from the dermis in vitro. And when you redo the IgG, that IgG linear pattern will be in the roof of that saline-induced split, which corresponds with the fact that the antigenic epitopes in BP lie above the salt split skin zone. And that's in contradistinction to, say, a condition called epidermolysis bullosa acquisita, which is kind of like bullous pemphigoid, but the antigenic epitope is type 7 collagen. And there you can imagine that if the technician repeated the assay, the staining would be really in the floor of the saline-induced split. So now we'll talk about pemphigus. Pemphigus, there are various types of pemphigus: pemphigus foliaceus, pemphigus vulgaris, IgA pemphigus, paraneoplastic pemphigus, and drug-induced pemphigus. For purposes of this talk, we'll talk about the two main forms of pemphigus, which is pemphigus foliaceus and pemphigus vulgaris. So in pemphigus foliaceus, one sees this superficial scaly erythematous eruption. In contradistinction, in pemphigus vulgaris, it is a severe blistering eruption with significant sloughing of the skin, with prominent oral cavity involvement. And before the advent of immunosuppressive therapy to treat pemphigus vulgaris, patients would actually die from this condition, as opposed to pemphigus foliaceus, which is the superficial variant, as we will discuss momentarily, that is not associated with mortality. So what do we see in this, superficial form of pemphigus, so-called pemphigus foliaceus? Well, the essence of pemphigus is an acantholytic dermatosis. So unlike bullous pemphigoid, where the integrity of the basement membrane zone is compromised by antibodies targeting the basement membrane zone, in pemphigus, the antibodies are targeting the intercellular junction that keep the keratinocytes together. So in pemphigus foliaceus, the antibodies are targeting an intercellular junction protein that is expressed at high levels in the superficial layers of the epidermis, referred to as desmoglein 1. And that antibody will cleave the intercellular junction superficially to result in this superficial acantholytic dermatosis that we refer to as pemphigus foliaceus, which reflects this autoantibody mediated condition targeting the superficially disposed desmoglein 1 within the epidermis. And note the separation of the superficial layers of the epidermis to produce this histologic picture of pemphigus foliaceus. In contrast, that very severe form of pemphigus, where patients could die in the old days when they didn't really know what it was mechanistically and had no idea how to treat it. Here, the acantholysis is very extensive and includes really a significant portion of the epidermis, especially the lower portion of the epidermis. And in fact, one of the hallmarks of pemphigus vulgaris is this so-called tombstone quality of the basal layer keratinocyte. So in other words, the basal layer keratinocyte is adherent to the basement membrane zone, but it is not attached to the adjacent keratinocyte. So it appears as a tombstone, like it's standing on its own. And so here we have these degenerated basal layer keratinocytes that are adherent to the basement membrane zone, but they're separated from each other, and there's a tremendous amount of intercellular adhesion in the lower two-thirds of the epidermis, ultimately leading to significant sloughing of most of the epidermis. And here, the antibody is targeting another intercellular protein that is expressed in high levels in the lower portion of the epidermis, referred to as desmoglein 3. And this is just a graphical abstract of the intercellular junction, showing the desmoglein 3 as well as the desmoglein 1. Both of these are transmembrane intercellular proteins, with desmoglein 1 being implicated in pemphigus foliaceus, while desmoglein 3 is implicated in pemphigus vulgaris. And when one examines these cases from an immunofluorescent perspective, the intercellular junction will be lit up in this sort of chicken wire pattern, highlighting the intercellular junction, whereby the antibody is targeting some component of the intercellular junction. And again, in pemphigus vulgaris, it is desmoglein 3 as opposed to pemphigus foliaceus, which is desmoglein 1. And the other variants of pemphigus, like paraneoplastic pemphigus and IgA pemphigus, there are other antigenic epitopes that are implicated, basically. And one point I'd like to mention is that in pemphigus foliaceus, there is no oral involvement because there is no desmoglein 1 in the oral cavity. In contradistinction, desmoglein 3 is at very high levels in the oral cavity and therefore accounts for the almost ubiquitous involvement of the oral cavity in patients with pemphigus vulgaris. So now we'll move on to the dermal reaction patterns, and we'll consider only two. A leukocytoclastic vasculitis is the prototypic Arthus type 3 immune complex reaction, and urticaria. So leukocytoclastic vasculitis will present clinically as palpable purpura. Some patients will have broad hemorrhagic bullous lesions. And so what does one see pathologically? It is a small vessel vasculitis that characteristically targets capillaries and venules. The vessels are surrounded and permeated by neutrophils. There's evidence of vascular injury revealed by luminal mural fibrin deposition and evidence of vascular compromise hallmarked by red cell extravasation. The basis of a small vessel vasculitis of the skin is oftentimes linked with circulating immune complexes, defining an Arthus type 3 immune complex reaction. And it should be emphasized that any patient who develops a cutaneous leukocytoclastic vasculitis could conceivably have a similar small vessel vasculitis in other organs, such as the lamina propria of the gut, the septal capillaries of the lung, leading to gastrointestinal hemorrhage and pulmonary hemorrhage, respectively. That same type of small vessel vascular injury could affect the kidney, resulting in a necrotizing glomerulonephritis. So a leukocytoclastic vasculitis can also affect other organ systems, and one is dealing with the same pathology, the same pathophysiology, independent of the organ affected. So here we have a classic presentation, palpable purpura, where you have raised purpuric lesions which do not blanch on compression. As I was mentioning, the vessels that are targeted are capillaries and venules. They will show evidence of vascular compromise with abundant red cell extravasation. When you have endothelial cell injury, you activate the clotting pathway, generate fibrin, which is entrapped in the wall and also found in the vascular lumens. And because classic complement pathway activation generates neutrophil chemoattractant factors, there is a migration of neutrophils into the vessel and into the perivascular tissue. And as well, these neutrophils undergo disintegration, referred to as leukocytoclasia. So we have the combination of vascular injury, inflammation, where those inflammatory cells undergo cellular degeneration or so-called leukocytoclasia, hence the designation leukocytoclastic vasculitis. And all, at least in this particular context for today, it is due to a circulating immune complex, whereby that immune complex will be an important trigger to classic complement pathway activation. You can trigger the classic complement pathway with an antibody bound to a cell or an antibody bound to basement membrane zone, as we saw with lupus and bullous pemphigoid, but also you can trigger classic complement pathway activation with an immune complex. And you can generate these components of complement pathway activation that can release inflammatory mediators and mast cell degranulation to eventuate into this highly inflammatory vasculitic process that will damage endothelium and activate the clotting pathway and lead to fibrin deposition and overall vascular compromise. Now, as far as the immune complexes, they could be exogenous, it could be a drug, it could be an infection. Certainly, when you look at limited cutaneous leukocytoclastic vasculitis, where there's no multi-organ involvement, oftentimes it is a drug. When you're dealing with multi-organ leukocytoclastic vasculitis, it can be an endogenous antigen, best exemplified by systemic lupus, for example, where you could get multi-organ small vessel vasculitis. And one of the classic endogenous causes would be an antibody bound to immunoglobulin. And an antibody that is bound to immunoglobulin is a rheumatoid factor. And so in autoimmune disease, an important etiology for the immune complex vasculitis, in fact, is a rheumatoid factor bound to immunoglobulin. And sometimes that rheumatoid factor bound to immunoglobulin, sometimes that immune complex has cryoprecipitable properties, and that would define a unique type of leukocytoclastic vasculitis, which is a mixed cryoglobulonemic leukocytoclastic vasculitis. Now, what about chronic idiopathic urticaria? Here we have patients that have urticaria observed for more than 6 weeks. And as it turns out, a significant percentage of patients who have so-called idiopathic urticaria, in fact, have antibodies, autoantibodies, that are targeting the alpha subunit of the high affinity receptor for IgE on mast cells, leading to mast cell degranulation. So in point of fact, a number of cases of urticaria represent a Jelen-Coombs type 2 immune reaction, where that autoantibody binds to IgE on mast cells and causes mast cell degranulation. With mast cell degranulation, you have eosinophils being attracted into the area, plus the mast cell degranulation leads to vasopermeability. So the urticaria that we see histologically related to this autoantibody binding to IgM mast cells would be translated histologically into a few mast cells and eosinophils in an interstitial and perivascular array with evidence of vasopermeability characterized by edema. And finally, we'll talk about briefly inflammatory conditions of the fat. And inflammatory conditions of the fat basically equal panniculitis. And panniculitis is a very fascinating and somewhat complex topic. Oftentimes, panniculitis can be a manifestation of systemic disease. For example, erythema nodosum can be a manifestation of a type 4 immune response to an exogenous antigen, but it can also be seen in patients with sarcoidosis and Crohn's disease. Erythema induratum is a unique type of panniculitis. It could be a sign of underlying Mycobacterium tuberculosis. It actually represents an id reaction to Mycobacterium. Patients with lupus erythematosus can develop a type of panniculitis called lupus profundus. We can see inflammatory infiltrates in the fat predominated by neutrophils, an actual neutrophilic panniculitis that could indicate a condition called subcutaneous sweet syndrome. That may be a manifestation of underlying myeloproliferative disease. Pancreatic panniculitis, it can actually be a presenting sign of pancreatic cancer. So panniculitis is an important reaction pattern that could signify certain diseases. And for purposes of today's discussion, we'll focus on possibly the most common type of panniculitis, which is erythema nodosum. It oftentimes does affect young adults. The anterior aspect of the legs are most commonly affected. The lesions are characteristically exquisitely tender. They are evolutionary, and the eruption will evolve over days and weeks. It can be accompanied by constitutional symptoms as well. And so what is it, pathophysiologically speaking? In many instances, not all, but many instances, it is an immune response to an antigen. And what could the immune response be due to? It could be a bacterial infection like streptococcal pharyngitis. One could even develop an id reaction manifesting as erythema nodosum in the setting of a distant fungal infection, certain drugs. Sometimes a tumor antigen, specifically lymphoma, can present with erythema nodosum. And this would be a typical clinical presentation, seeing these erythematous plaques on the leg. And so what does one see? Well, as I was mentioning, it is a type, it can be a manifestation of a type 4 delayed hypersensitivity reaction. So one will see expansion of the septa of the fat. So it's a septal panniculitis where the infiltrate reflects Th1 type 4 immunity. And by that, I mean we will see epithelioid granulomata intimately admixed with T cells. And so what one is seeing here is a septum in the fat. Here is the adjacent fat lobule where that septum is expanded by collagen, but an inflammatory cell infiltrate that represents this classic Th1 dominant delayed type 4 immune response where you have a collection of histiocytes, including Langerhans giant cells, admixed with T cells. And your job as the clinician is to try to elucidate the antigenic trigger, be it in the context of a perineoplastic syndrome, possibly a drug, or an infection that may have elicited this erythema process. And it should also be emphasized that there are a few diseases, namely sarcoidosis and Crohn's disease, that can manifest with erythema nodosum. That's it. Thank you.